speakers to this 24 TUGS India academic program. Myself, Dr. Vikas Jain, the TUGS India and Asia coordinator, and we are running this program successfully from last 2 years. More beyond the webinars, TUGS is a registered charity in UK focused on upper GI, hernia, and other general surgical topics. And we have a future vision for the extensive academics over the 29 member countries in the world. Fortunately, we have more than 4,000 members over a short duration of 2 years. So today's program is focused over the basics of acute pancreatitis management, which includes the etiopathogenesis, diagnosis, and initial management by our esteemed panelists and speakers. So first of all, I invite our three panelists on board. First is Dr. V.K. Pratapan, who is a professor and HOD in surgical gastroenterology in Government Medical College, Kozhikode, Kerala. Second is Professor Manohar Dhawan from the SP Medical College, Bikaner, Rajasthan. And the third one is Dr. Sharad Malhotra. Probably he is not able to join today. He's the department in medical gastroenterology in Akash Hospital, Dwarka, New Delhi. With that, I would like to invite my co-host and the reputed TUGS India executive member, Professor Manas Ranjan Sahu sir, who is HOD in Department of Surgery in AIIMS Bhubaneswar. Now, without wasting time, I request Dr. Manas Ranjan Sahu sir to have some words for our speakers and delegates, just for the few lines. Dr. Manas sir. Dr. Manas sir, are you there? Okay, probably he is online, but not sitting on the chair. Okay, anyway, with that, now I invite my first speaker, Dr. Rashmi Ranjan Mohanty, who is a professor in Department of Medicine, AIIMS Bhubaneswar. Today, he will be enlightening us about the genesis and natural history of acute pancreatitis. Over to Dr. Mohanty, sir. Dr. Mohanty,
Good
sir.
evening,
Yeah.
all. Am I audible?
Yeah, you are audible.
Okay, let me share my screen. My slides are visible.
Yeah, it's visible. You can start, sir.
Good evening, everybody. Today, I have been assigned to talk on genesis and natural history of acute pancreatitis. Am I clearly audible?
Yes, sir, you are clearly audible. If you can do, can you make it a full screen?
Okay.
Yes.
Yes. Okay. So it's always interesting to know the natural history and pathogenesis of any disease because it will enlighten us regarding how the disease progress, where we can intervene, and at what point it may be very fatal. So before starting my talk, I would like to confess that with this talk, I have no conflict of interest, and all the data I show are from the open source and they are available in the public domain. And I have cited them in my slides. So the overview of my talk will be how a acute pancreatitis develops and it progresses with or without treatment. Then I will talk about why acute pancreatitis happens, then what precipitates acute pancreatitis, and how the pathologic event uh, uh, unfold to cause the acute pancreatitis. And at last, I will tell some benefits by knowing all these things. So, coming to the natural history of acute pancreatitis, we can see the slides from a very famous publication that is published in the Journal of Gastroenterology. It is a study done on Danish populations, and it is a very long study spanning about 16 years. And it took four disease states, that is acute pancreatitis, recurrent acute pancreatitis, chronic pancreatitis, and pancreatic cancer, and one end result, that is death. So we can see from the picture that in a lifetime, a person from no pancreatic disease can directly go to acute pancreatitis, can go to chronic pancreatitis, or can go to pancreatic cancer. And with complication, with treatment, he may improve or he may go to death. The overall most important and most common natural history is usually acute pancreatitis goes to acute pancreatitis go to recurrent acute pancreatitis, then gradually it goes to chronic pancreatitis, then some may go to pancreatic cancer. So this is the most common natural history or natural pathway of a person who develops acute pancreatitis. That means he will go to recurrent pancreatitis, then chronic pancreatitis, then he may develop pancreatic cancer. But there are some situations where a patient without developing acute or recurrent pancreatitis may go to chronic pancreatitis or may go to pancreatic cancer. So, in this natural history, I would like to enlighten some points that these are some non-modifiable factors that are important in development of acute pancreatitis and their history. First is age. In If a person develops pancreatitis at younger age group, the most common natural history is it go from acute to chronic. But if a person develops a pancreatitis at later age group, most commonly he directly go to chronic pancreatitis uh, without suffering any acute episode. So this transit is dependent on the age and also sex. Male sex are very much prone for acute pancreatitis and recurrent pancreatitis due to their more alcohol use and more other risk factors. So if we see overall the natural history, we can divide the pathophysiologic pathway into two groups. That is one inflammatory driven pathway and the second is fibrosis driven pathway. So a person going from acute to recurrent pancreatitis usually go through inflammatory driven pathway. A person who goes directly to chronic pancreatitis usually goes through fibrosis driven pathway. So now let's discuss why this acute pancreatitis develops. We know that pancreatitis is an inflammation. It is not an infection. It is an inflammation which is secondarily infected. Like other infective disorder where there occurs first infection, then the hyperinflammation state, here occurs totally opposite. First there is inflammation and that inflammation is secondarily infected. So this inflammation usually occurs due to loss of autoprotection inside the pancreas, and that leads to auto digestion of the pancreatic acinar cells. So we can divide the acute phase into three stages. That is first the initial stage where the enzyme activation and acinar cell injury occurs due to activation of trypsinogen to trypsin. So this is the most commonly accepted pathophysiologic mechanism, and it is the major pathophysiologic mechanism, though there exists some other pathophysiologic mechanism that can go without trypsinogen activation. So in this initial phase, if this control, the patient may improve, or he may go to second phase, that is activation of and chemoattraction of different leukocyte different products that are released from the leukocyte, and the inflammatory process goes on. If it is uninhibited, then it goes to the hyperinflammation stage. Then there is sepsis and other organ involvement. So this is how the acute pancreatitis progress. So what are the things that precipitate acute pancreatitis? So there are four conditions that are responsible in combination for development of pancreatitis. That is loss of protection. We know that there are different protecting mechanisms inside the pancreas that prevents the activation of trypsinogen to trypsin inside the acinar cell or duct. If these protective mechanisms are lost, then there occurs activation inside the acinar cell and duct, and there occurs pancreatitis. So this activation usually occurs due to some risk factor. The major risk factors are gallstone and alcohol and hypertriglyceridemia. Other than that, there are many drugs that can precipitate pancreatitis. Trauma to the pancreas, either iatrogenic or any other trauma, any post-operative procedures, many vasculitis and many infections, hypercalcemia and autoimmune disease also can precipitate pancreatitis. In all these risk factor driven pancreatitis, the most common pathophysiologic mechanism is activation of trypsin from trypsinogen due to obstruction of the obstruction of the duct and accumulation of the pancreatic fluid inside the acinar cells. But there are some causes of pancreatitis like different hereditary causes where there may not be any obstruction. There occurs mutation in the protective or inhibitory genes that leads to accumulation of trypsin, or they may take separate pathway for development of acute pancreatitis that I will discuss further. And in some cases, there may not be any apparent cause, and the patient may not have any risk factor or any hereditary predisposition, still he develop pancreatitis. So from this, there may be some other pathway that we don't know that is independent of trypsin activation that can lead to acute pancreatitis. So once the acute pancreatitis develops, it goes through different phases like early phase and late phase. In early phase, we usually tell within 2 weeks, late phase more than 2 weeks. The severity of pancreatitis can be assessed by the clinical parameter and imaging parameter. The clinical parameter, by clinical parameter, we can divide it into early, moderately severe, or severe pancreatitis. And by imaging parameter, there are different uh, nomenclatures like interstitial pancreatitis, necrotizing pancreatitis, pancreatic pseudocyst, and there are walled up necrosis. So there are different nomenclature according to the image criteria. And the severity usually assessed by the modified Marshall criteria. So this table shows basically on the imaging parameter, we can divide all the pancreatitis into two groups, that is interstitial edematous pancreatitis and necrotizing pancreatitis. And they usually goes into acute peripancreatic fluid collection and pseudocyst, or necrotizing fluid collection and necrotizing walled up pseudocyst. And this picture shows all the variety can be sterile or can be infected. The black portion is infected, the colorless portion is the sterile. So there may be chance of infection in all the types, and as the inflammation progresses, there is more chance of infection. And the outcome, usually 80% of acute pancreatitis are simple and with very less mortality like 0.1%. Among the another 20%, around 67% goes to sterile necrosis and 33% goes to infective necrosis. So if the necrosis is sterile, the mortality is around 13%, and the necrosis is infected, the mortality increases up to 35%. Then comes how it develops, or what is the genesis, why pancreatitis develops. So we can see into these three important papers that will throw light on the pathophysiologic mechanism of pancreatitis. First, coming to trypsinogen activation peptides assay in early prediction of severity of acute pancreatitis. This study shows they have developed an antibody against trypsinogen activation peptide, and that measures the level of trypsinogen activation peptide in blood or urine. And they have seen that as the severity of pancreatitis increases, the amount of this trypsinogen activating peptide increases. So this study establishes the hypothesis that trypsin is central to the development of acute pancreatitis. But there are few other studies that is coming up very recently, like intra-acinar trypsinogen activation may be the initial stage, but it doesn't propagate to very severe pancreatitis without help of other parameters. And in another study where a supramaximal dose of CCK or cerulin induces chronic pancreatitis in mice without any increase in the trypsin activation. So these two studies proves that there are other pathway along with trypsin pathway. So we can divide the pathophysiologic mechanism of acute pancreatitis into two groups. That is one trypsin centric mechanism, another is non-trypsin centric mechanism. So coming to trypsin centric mechanism, here the central role is early activation of trypsin in the acinar cell and ducts. The activated trypsin co-localizes with the lysosomes of the acinar cells, and along with lysosomes, with the help of cathepsin B, they release into the cytosol, and the cathepsin B also release into the cytosol, and then the inflammatory cascade unfolds. And here, the inflammatory cascade depends on the level of cathepsin B in the cytosol. If the level is low or moderate, then the inflammatory process goes and there occurs apoptosis. So apoptosis causes end of the inflammation and it become only a uncomplicated acute pancreatitis. But the release of cathepsin B is very heavy. Then it goes to the necrosis pathway. So with necrosis, the cascade goes on, the vicious cycle goes on, and the patient goes to severe pancreatitis and far more other organ involvement and to sepsis. So this is the overall mechanism of trypsin-centric pathogenesis of pancreatitis. Then what are the other non-trypsin centric pathogenic mechanism? The non-trypsin centric pathogenic mechanisms are production of damage associated molecular patterns. So these then production of neutrophil extracellular traps, production of microbe associated molecular patterns, production of pathogen recognition receptors, and production of activated uh, natural factor kappa beta. So coming to little bit mechanism of production of damage associated membrane proteins. These are the proteins they are produced actively from the different immune cells or from the necrotic pancreatic acinar cells. They can be produced directly, or when there is maltrypsin activation, they can produce and add to the pathogenesis of pancreatitis. And the overall pathogenesis leads to necroptosis, pyroptosis, ferroptosis, and apoptosis of the acinar cells, and the cascade goes on as more and more inflammatory cytokines released. Similarly, your neutrophil, there are some circulating inflammatory markers also released from the activated neutrophils, and they also help in maintaining this cascade. And another important mechanism is gut microbiota dysbiosis. So if the patient remains on parenteral feeding for long times, the permeability of gut increases and microbes enters into the circulation and they produce different inflammatory markers that will again propagate the progression of the acute pancreatitis. So it is always advisable to start early diet and restore the gut microbiota in acute pancreatitis as quickly as possible. So as we know that these are now coming up as new target agents for therapy. So many study are going on and they are in phase 2 or phase 3 trial for development of new drugs that can decrease the expression of the DAMPs, that can enhance the DAMP elimination, or that can block the DAMPs signaling. So this is the overall pathogenic mechanism by which acute pancreatitis develops and propagates. So to summarize, early activation of trypsinogen in pancreatic acinar cells and OX is the major pathway for initiation of acute pancreatitis. It is the central pathogenic mechanism. But for maintenance and propagation of the pancreatitis, then other inflammatory cells are must or required. And mostly the inflammation occurs starts by the autophagy and propagates by necroptosis. So there are many potential targets that can be explored for future therapeutic options. Thank you.
Thank you very much. Any role of CRP in the acute pancreatitis prediction?
Sir, we'll discuss the question answers after finishing all three talks.
Okay.
Yeah. So thanks, Dr. Mohanty, to make such a basic history of pancreatitis so clear to the delegates. Now I invite Dr. Nistala Srinivas, who is a Chief Consultant Medical Gastroenterologist in Medicover Hospital, Visakhapatnam. Today, he will be explaining us the role of ERCP in diagnosis and management of acute pancreatitis. Over to Dr. Srinivas.
Yeah. Thank you, Dr. Vikas. Can you see my slides and can you all hear me clearly?
Yeah.
Right. So, Dr. Vikas, first of all, thank you for inviting me to this fantastic forum. And I was told that the two subtopics in general, assessment in acute pancreatitis and ERCP in acute pancreatitis. That was the things I was told.
Yes.
If I'm not wrong.
Yes.
So, shall I proceed with that?
Definitely.
Right. Yeah, thank you. So there are some slides which I may actually skip because of repetition or shortage of time. So we all know the diagnostic criteria of acute pancreatitis. Two of the three, pain, lipase and amylase elevation, and abdominal CT. But if we take only two of the three criteria, 1/4 of the patients can be failed to be diagnosed and 1/10 of the patients can be misdiagnosed. So we should be careful when you're just sticking to that very strict criteria of two of the three. So assessment of acute pancreatitis begins in the emergency room with clinical assessment of the severity. Scoring systems in assessing pancreatitis is a very big topic in general, but I'll try to see what justice I can do to this topic. And third is radiological assessment of the acute severity. So in this cartoon, I can show that the top left portion of the cartoon shows a mild acute pancreatitis where there is mild swelling of the pancreas with little inflammation, and the patient recovers in the next 3 to 4 days. In the bottom right, there is massive inflammation, as told by my previous speaker, leads to a lot of necrosis of the pancreas and also multi-organ damage in the form of kidney and lung failure. So two phases of acute pancreatitis, very, very important. That is plainly seen in the severe acute pancreatitis thing. The early phase is less than 1 week, and the second phase of more than 1 week, which leads to local complication and also multi-organ system dysfunction and also death. So coming to the assessing of the patient in the EMR is paramount because it is when the first time you see a patient and you can have a first-hand information, first-hand feel how the patient is going to behave. So that comes over a time with clinical experience and also with the practice. So mild acute pancreatitis as defined, absence of organ failure, absence of pancreatic necrosis, and recovery starts in 48 hours. But remember that not all patients of severe acute pancreatitis present with organ failure or necrosis to the emergency room. So this is very, very important. Just because the patient is not having any symptoms of organ failure, don't think that he is in mild acute pancreatitis. So do not label patients as mild or severe acute pancreatitis within 48 hours of presentation because that is the time it is required for the inflammation to set in and develop its peak. So these are some routine clinical parameters which usually will help us see how sick the patient is or how severe the patient is going to become. Older age group, obesity, altered mental status, and comorbid diseases. These are very, very basic things. None of these are useful nowadays, but still, if you are in an emergency situation, once you see a patient of an older age group, obese and altered mental status, you can straight away clinically say that the patient is going to become more sick over the next few days. So these are all other risk: tachycardia, hypotension, hypoxia, and these are the other laboratory parameters which we'll discuss in future. So we all know the different criteria for classifying acute pancreatitis. First given in 1993, revised in 2013. And from 2013 onwards till this date, we are following this particular criteria to define mild acute pancreatitis, moderately severe acute pancreatitis, and also severe acute pancreatitis. So there is one other classification which is not used very commonly, but that is also very, very important. But I didn't get that much of appreciation compared to the Atlanta classification. The main difference between the Atlanta one and the determinant-based classification is local complications. It also defines whether local complication is a sterile complication or an infected complication, which is not seen in case of Atlanta classification. So how to define organ failures? All the critical care guys are very well versed with it. We just need to know modifier Marshall scoring system is something, and SOFA score. These are two different scores which are helping in identifying the organ dysfunction. So this is the basic things, and we'll see what all the things we have to see the assessment of acute severe pancreatitis. So multiple scoring systems are there. The Ranson score, modified Glasgow and Emery score, bedside index for severity of acute pancreatitis, harmless acute pancreatitis score, Apache 2 score, PANC 3, and Japanese severity score. So why so many scores? Because none of them is perfect. So when you have multiple options, it means that no one option is perfect. So just because the pancreatitis is such a heterogeneous group of disorder, and once it becomes a multi-system involvement, then it becomes so heterogeneous that one scoring system actually cannot help in diagnosing the severity of the patient. All the scoring systems, most of them are very complex. They are time consuming, not useful at one single point. In the sense, if you have a patient, if you need to see, if you have a patient you're seeing at day 0 or day 1 or day 2, so there is not one scoring system which will actually tell you that this particular patient is going to become sick or not going to become sick. So at one particular point, they're not very, very useful. But if you want very simple scoring system, this is BISAP, is the simplest of the scoring systems. Most of the people can use at their clinics also. What is this? It is bedside index for severity of acute pancreatitis. It takes blood urea nitrogen, impaired mental status, SIRS, age, and pleural effusion. So if based on these things, you have a score total of 5. If the score is more than 3, it is 7 to 12-fold increasing the risk of organ failure. So this is the simplest one if you want to use to assess the patient who is going to become sick or not going to become sick. Most of the clinical scoring systems are accurate in differentiating mild and severe pancreatitis, but only up to 70%. They're not very, very sensitive. But if you wait for next 24 to 48 hours, they become little more sensitive. It increases to up to 80%. So most of the standard or previous ones, the Ranson scores, all these, they used to take at day 0 and day and 48 hours. So this is the drawback with scoring systems. And of the readily available single markers, C-reactive protein is the most important one, especially on the second day of admission. If you see a patient who is having a C-reactive protein which is gradually increasing even in the second day, then this is the patient who is going to develop multi-organ failure or going to develop local complications. And this can help us guide radiological investigations in the next 1 week or 2. A lot of studies there, a lot of literature is available all over the internet. And this main studies I brought it from, this is published in the World Journal of Gastroenterology 2023. They have compared multiple scoring systems to see which is better. The whole study, the whole paper was on comparing the multiple scoring systems. So I picked up 2-3 important tables from this particular paper. I'll show you this. So they have studied BISAP, Ranson, Apache, and modified CT severity index to know whether which can predict moderately severe or severe acute pancreatitis. Of this, they have found out that the area under curve is maximum for Apache 2. And similarly, this is a big study, 326. This other study is 653 people. And they have seen that it is the SOFA score which has the maximum maximum specificity when you want to see whether the patient is going to develop a moderate, severe acute pancreatitis or not, and the area under curve is also maximum in this. So from a predominantly gastroenterologist point of view or a surgeon point of view, the acute severe pancreatitis is now a multi-system involvement and a team approach, because once the patient develops multi-organ failure, a critical care team actually comes and plays a very big important role. So it is all these scores, Apache 2 and the SOFA score and the Q-SOFA score, these are used mainly in a critical care setup when the patient develops multi-organ failure. It is beyond the realm of just the pancreatologist or the gastroenterologist. A multi-system involvement gives us a most important thing. And these are the two scores which are mainly used in the critical care setup rather than at the clinical level. Similarly, a lot of studies which have compared the mortality and the prediction by the scores. Once again, the Apache and the Ranson, these are the two ones which have found to have largest amount of area under curve. So Apache and Ranson or the SOFA score, once the patient develops a multi-organ involvement of the pancreatitis, so you need to use scores which are not limited only to the abdominal cavity or the pancreas per se. So what does the IAP and the American Pancreatic Association say? They say that SIRS, which is part of the BISAP score, it is one of the best predictors for acute severe pancreatitis at admission and also at 48 hours. So this table tells us what are the parameters which are present in SIRS. So we should all be well versed of the basic things, especially SIRS and BISAP. These are the two common things which we can use to see, which can predict which patient is going to become going to very severe acute pancreatitis. So as I was telling, a lot of studies have done for comparing the various scoring systems to tell which scoring system is better or which is not very better. So this is one study published in 2012 Gastroenterology. They compared 161 patients. So what they found, they studied all these 5-6 scoring systems. They found that Apache more than 8, Ranson more than 3, BISAP more than 2, CTSA more than 3, and CRP of more than 21 at day 48 hours. All these things are showing that the patient is going into severe acute pancreatitis. But of all this is the Apache which has the, sorry. For all this, it is the Apache system which is having the highest accuracy in predicting the severe acute pancreatitis. Summarizing the assessment and different scoring systems which needs to be used. Scoring system utilize 4 to 25 factors have been developed to predict the severity, but they frequently rely on multiple parameters which are not measurable very readily, often require over 24 hours to finalize and stabilize. They're sometimes inconsistent, they're complex sometimes, lack of sensitivity and specificity at particular etiologies, lack of personalization and over-reliance of scoring system is not always advisable. You should see the patient clinically, that is most important. There are multiple apps which are available in the net, like Easy app. This is a Sweden-based group which has developed this app, and there's an app called as Pass app, which can actually tell. The second part of this is radiological assessment. So CT and MRI are equal in assessing the pancreatic necrosis. MRI scores over CT over in 3 particular situations: when the patient is in renal failure, when there is contrast allergy to the patient, and want to look at the CBD stones. And it can also help in looking at the PD disruptions. But when do you do, what do you do when you do a radiological investigation? In the first 1 week, you establish a diagnosis and to find out alternate diagnosis, to find out the etiology. And in the second week or after the first week, you try to actually look at the local complications and plan management interventions. CT is the most important investigation. It plays a very pivotal role in assessing the scope of progression of acute pancreatitis. It is the most primary modality to pinpoint local complications also. What are the things which are looked in? Pancreatic enlargement, edema, uneven density, fat stranding, and fluid collections. So first developed by Balthazar, that is Balthazar grade, then modified by Moretel, that is called modified CT severity index. So these are the two commonly things. Once you send a patient to CT, you get a CT scan report, and the impression will say that modified CT severity index is so and so and so and so. So this is how all these things have come up. So there is something called as MR severity index also. So we all know how difficult it is to get an MRI done in a patient who is actually sick or on a ventilator or some high flow oxygen. So it is not very commonly used in Indian setup especially, but maybe when the patient is in very early acute pancreatitis, first 24 to 48 hours of the disease, you may use this MRI thing also. So this is the modified CT severity index. So the extra thing compared to the previous one, Balthazar grading, what they found out is they have taken two important things. They have taken the extra pancreatic complication, and they have reduced the necrosis component to less than 30, 30 or more, and more than 30. So this is the main difference between modified severity index and the CT severity index. So in this CT scan, I'll just briefly run you through this. So this is non-contrast image, mild bulkiness of the pancreas, contrast image showing this is day 1 of presentation. So mild peripancreatic fluid around the tail of the pancreas and anterior to the kidney. In this, if you see the disease has progressed, the peripancreatic fluid collection has increased, and there is a necrosis in the body and head of the region, and the tail is still, it is little viable. So this is at day 20 where it is showing a large collection and compressing the stomach. So this is how a CT scan progresses over the next 2 to 3 weeks. So there are a lot of studies which have compared the mortality outcomes or the intervention rates in a patient based only on the CT severity index. So what they have seen is that if the patient is having a severe disease, the chance of mortality, chance of intervention is of course very high and is a very significant. One of the important things, especially after the first 5 to 7 days of the disease, it is a CT scan which can help us prognosticate the patient. So this is the MR severity index. We are not very routinely using this. So, but if someone wants to know, and we can always do this. The second part of my talk is ERCP in acute pancreatitis. So once we have established the patient is having acute severe pancreatitis, and what are the interventions we can do immediately to settle the patient, not wait for 4 weeks for the necrosis or other pseudocysts to develop. So ERCP in acute pancreatitis, first thing is whenever the diagnosis is of acute biliary pancreatitis, there is a role of ERCP. How to confirm whether the bilirubin, alkaline phosphatase, or AST, which is the most important thing? No, the most important thing is ALT more than 3 times upper limit normal. So that suggests biliary acute pancreatitis. This is the most important thing to remember. Ultrasound, though very good for gallbladder stones, it is not very good for CBD because less than 20 to 30% are picked up. MR, CP, and EUS are definitely used to know whether there are CBD stones or not. These have a very high negative predictive value and always should be done before you're contemplating a patient for ERCP. Always do a EUS or an MRCP, diagnostic EUS or an MRCP. So this is the simple cartoon which shows why acute pancreatitis develops because of CBD stones. So this is the CBD and the PD common channel. Stone gets blocked, the pressure increases, and the cascade sets in of acute pancreatitis. So you put a wire inside, you pull out the stone, and the pressure gets reduced. So the most important question is to do it or not to do it. So this is the most important question. So most of the guidelines which say that no ERCP in mild acute pancreatitis. If the patient is having mild acute pancreatitis at 48 hours of the disease, so there is no need for early ERCP in these kind of patients. But if the patient is having cholangitis or evidence of any biliary obstruction which is persistent, early ERCP is definitely advisable. Coexisting biliary obstruction without any symptoms, incidentally you have found out a patient with CBD stones, but there is no evidence of cholangitis or anything, then yeah, maybe you can do an early ERCP. So mild acute pancreatitis, no role of early ERCP. Cholangitis and evidence of biliary obstruction, yes, definitely there is role of ERCP. So these are the guidelines for, these are the criteria for cholangitis, how to diagnose a patient of whether he has cholangitis or not. Counts are high, bilirubin is high, but without any organ failure in the form of hypotension, neurological disturbance, no renal failure, no respiratory failure, having moderate amount of cholangitis. So whenever the patient has cholangitis, you should take him for ERCP immediately. So now the other important question comes, what to do when the patient is neither having severe mild pancreatitis, when you don't do ERCP, is not in cholangitis. So this is the important question here. Early ERCP in patient without cholangitis, but who are likely to have severe acute pancreatitis. So this is the group of patients where we are left with. We have a patient who is having severe acute pancreatitis, but is not in cholangitis, but still has some amount of CBD stone. So this question was answered by the EPIC trial, which was published in 2022 in Lancet by the Dutch group. Urgent ERCP with sphincterotomy versus conservative management in a patient with predicted severe acute gallstone pancreatitis. So they have randomized 232 people. They randomized 232 people. 118 got ERCP and 114 got standard conservative management without ERCP. Mind you, these are patients with acute severe pancreatitis, but they are not in cholangitis. So what they found out is the primary combined endpoint was death or severe complications. So they found out that there was no statistically significant difference between the two groups regarding the composite primary endpoint, but cholangitis was high in the medically managed group, counterbalance, and the patient who were managed with ERCP, they had increased ICU transfers and new onset respiratory failure. So the primary endpoint of death and severe complications was same in both the groups, but they have found out some in-group variations. So the authors concluded that in patients with predicted severe acute pancreatitis without cholangitis, the superiority of early ERCP with sphincterotomy compared with conservative management could not be suggested. Hence, it is not recommended in patients without evidence of any cholangitis. So this is the concluding slides of mine. Early acute biliary pancreatitis. Once you have acute biliary pancreatitis, first thing you need to find out is whether you have cholangitis or not. Look at the Tokyo criteria. If you have cholangitis, you take the patient for ERCP as soon as possible. Once the patient has no evidence of cholangitis, then look for whether there are any signs of biliary obstruction. If there are signs of biliary obstruction, then you go for ERCP. Don't go for an urgent ERCP. You can wait for 2 to 3 days for the patient to settle, and then you go for ERCP in these kind of patients. But if there is no evidence of biliary obstruction, as I told, before going for an ERCP, you should always go for a diagnostic EUS MRCP. Then only you should venture into for an ERCP. So if either EUS and MRCP shows CBD stone, then you go for ERCP. If there are no evidence of CBD stones in either EUS or MRCP, you should not go for an ERCP in this patient. In case of cholangitis, yes, it is the indication is very pretty obvious. If the cholangitis is severe, as soon as you see the patient, you take him for this is called urgent ERCP less than 24 hours. If the patient is otherwise stable, you put him on some antibiotics, stabilize him, and then you go for ERCP at a little later date, 1 or 2 days later, the presentation. So this is my team, and this is the golfers, beautiful golfers which we have in Vizag, and I'm ready for any questions.
Thank you, Dr. Srinivas. We have few questions, but we will discuss it after finishing all talks. So now we will invite the jewel of the gastroenterologists in India, Dr. G.V. Rao, sir. He's a director in surgical gastroenterology in Asian Institute of Gastroenterology in Hyderabad. Today, he will be speaking on initial management of acute pancreatitis with and without necrosis. Over to Dr. Rao, sir.
I'm sorry. Thank you so much. Actually, can you hear me and see my slides?
Yes.
I was given to understand that I was supposed to talk on wall of pancreatic necrosis, and basically because the management of surgical management in the acute phase is predominantly medical, and as very clearly illustrated by the previous speakers, most of them are managed conservatively, or if at all required, endoscopic interventions or ERCP interventions are done to take care of this patient. Is that okay?
Okay. It's okay, sir.
Right. Now, like once the patient sets in for an infected pancreatic necrosis, the surgical management, surgery has been the gold standard for the management of this patient with infected pancreatic necrosis. Now, all the concepts of current day clinical practice have all evolved from surgery. The basic thing is actually we try to delay as much as possible. We drain the infected pancreatic, the fluid around with the infected pancreatic necrosis. We debride the necrosum. And if you deviate from any of these things, basic standard SOPs that have been practiced, there has been not evidence to show that it is associated with increased mortality and morbidity in these patients. So the first paper which came in actually the 2010 actually immediate was postponed intervention. Actually we tried. There is a lot of data which is coming up which is to show whether immediate versus postponed interventions in infected pancreatic necrosis. Initially, we tried the same concept on the surgical side, but it showed that early intervention is associated with increased morbidity and mortality. But the current evidence shows that there is a small segment of patients which require an early intervention as compared to the delayed intervention in these patients. Now, if you look at infected pancreatic necrosis, the interventions in pancreatic necrosis are surgery, endoscopy, or radiology. These procedures are either done independently or sometimes they are done sequentially. You have the radiology followed by surgery, endoscopy followed by surgery, or surgery followed by radiology, surgery followed by endoscopy. All these three modalities are interlinked, and it is possible that we have sequential procedures that are done to overcome the infected pancreatic necrosis. Or sometimes you do a combination of this. It is a combination of surgery with radiology, surgery with endoscopy, or endoscopy with surgery, endoscopy with radiology. So there are several permutations and combinations that are available in current day clinical practice, depending on the condition of the patient, depending on expertise available across the centers, and depending on the extent of necrosis that we see in these patients. So as in today, all three modalities seem to have an important role, and the role of individual modality depends on the expertise, the site, the condition of the patient. All these are taken into account before we try to plan for intervention in these patients. Now, if you look at this, surgery has been the gold standard. Actually, minimally invasive techniques came in a big way. Intervention radiology, endoscopy came in, and then subsequently the last to enter was the minimally invasive laparoscopic surgery. The mortality morbidity significantly decreased with the introduction of minimally invasive procedures into clinical practice, but most of us, we keep thumping our chest saying that the endoscopic, radiological, or surgical interventions are responsible for the decreased morbidity and mortality, but it is the critical care and the ERAS protocol that are practiced that are responsible for the decreased morbidity and mortality in addition to the interventions that are done. Now, there is a lot of data to show that the improved outcomes are basically because of the enhanced recovery protocols and the critical care management that is done in this patient. And we have to give credit to the intensive care people who are taking care of this patient, and which is also responsible for the decreased morbidity and mortality. There are several issues that are concerned as of today, depending on the quantification and the qualification of debris necrosum, the site and extension of the necrosis, selection bias. There is a lot of selection bias in the published series, and can be done is not should be done. It all depends on the functional status of the patient, expertise available, as I told you, and also the financial status of the patient. Now, the first thing that changed from surgery to other modalities is this Panther trial, which came in 2010, which showed that you can drain this infected pancreatic necrosis initially, and subsequently go in the retroperitoneoscopic axis and do a debridement. This, though a small number of patients were done in these patients, it has shown that it is significantly superior to conventional open surgery. This is what is called as a step-up approach or open necrosectomy for pancreatic necrosis. And they've also published their long-term follow-up in this patient and showing that the endocrine insufficiency, these patients did very well, and they feel that infected step-up approach is best for these patients with infected pancreatic necrosis. Now, subsequently, endoscopic management came in a big way, and Todd Barron was the first person who changed the entire concept in which how the endoscopic started defining this infected pancreatic necrosis, and Todd Barron created this definition of walled-off pancreatic necrosis. Now, this is basically whenever we have fluid component, it is called as a pseudocyst. And whenever we have debris in the thing, it is called as walled-off pancreatic necrosis. This is the basic difference in the definition. And if you see what we do on surgical practice, suppose if you do this necrosectomy in this patient with walled, now this is what is called as the debris that we see, or this is what is called the necrosum that is seen in this patient. Now, in 2024, now most of the interventions are endoscopic ultrasound based. Now, once you quantify want to quantify this patient by various cross-sectional imaging, once the whole thing gets organized, it is likely that we initially assess this patient with an endoscopic ultrasound to see the feasibility of draining internally. And US is very, very sensitive to detect fibrosis. So what has happened was whatever pseudocysts that we initially used to term based on the CT findings, they have become endoscopic ultrasound walled-off necrosis. In the sense, basically, even if there is small amount of debris in the collection, it is termed as a walled-off necrosis. But surprisingly, what has happened was compared to the previous publication, now most of the ones in current day literature that are there are all CT pseudocysts that we used to talk about. Now, endoscopic approach came in a big way, US guided drainage, and we from our own data center have shown this endoscopic step-up approach using this lumen opposing stent is a good modality to do this. But surprisingly, what happens is we have also shown that majority of these patients do not require any necrosectomy. If you see this data that we have, almost majority, 70% of these, or majority of these patients, 75% of these patients do not require any intervention, and very small percentage of these patients require some sort of debridement, and even these patients who require debridement are almost about another 15 to 20% are simply done by unclogging the stent, but direct endoscopic necrosectomy is required only in about 10% of these patients. So it means to say that endoscopic step-up approach, that majority of these patients can be managed by simply putting in a stent to letting out the fluid, and that small amount of debris will automatically get evacuated, and only small percentage of these patients require endoscopic necrosectomy. We have other modalities that have come in right now for these patients actually who have this debris. Now we started using this snails, baskets to debride, and also we have this endorotator which has come into clinical practice, which can be used to extract the debris in one sitting, but majority of the time it so happens that depending on the amount of necrosum we have, it might require multiple sessions to do a complete debridement. Now, we also started using hydrogen peroxide as an adjuvant to clear up these things actually, but though there is technical risk of air embolism in this, but this has shown to be quite useful in these patients with infected pancreatic necrosis, and it augments the clearance of debris whenever using these endoscopic procedures. The other modality is radiology plus endoscopy. That I told you that we have this combination of technologies coming in. Now, here is one such patient who initially it was drained using radiologically, you put a percutaneous drain. Subsequently, you go in through this endoscopic tract through this and do a debridement. Now, you can go through this tract directly, or you can put in a fully covered stent and go into the wall of pancreatic necrosis through the through this fully covered stent that it can be put across in the tract. Now, there is a lot of data coming in to show that various modalities can be used. I hope you can understand that you have this US guided drainage and percutaneous necrosectomy as a dual approach. Now, initially we used to do one procedure after the other, but now it is possible that you can combine both the procedures at the same time. You have both endoscopic procedure and the percutaneous procedure done at the same time. And also we have these procedures like endoscopy and surgery can be combined. Here is one such patient who you can anchor the stomach to the anterior abdominal wall. Subsequently, you can put a trocar directly into the stomach, and subsequently you can take out this lumen opposing stent and do a wide cystogastroscopy here. Or likewise here in this patient, actually, this is a conventional cystogastroscopy that is done. This is what is done minimally invasive pattern. But the biggest problem occurs when this walled-up pancreatic necrosis extends across either into the thalacoric regions or into the mesentery or into the mediastinum. This is what is called as extended walled-up pancreatic necrosis. In centers of excellence, some of these things are managed either by interventional radiology or endoscopic methods. Like we have this combined endoscopy and interventional radiology procedure. You can see this endoscopic, it is drained, and then you can see the scope coming out through this percutaneous route. So this combined endoscopy and radiology procedures can be done, and they also started talking about these extended paracolic cutters, which are coming deep into the pelvis, can be drained transrectally using endoscopic ultrasound. So depending on the expertise available, various centers practice these various modalities, and the data coming up is limited, especially in cases of extended pancreatic necrosis, but increasing expertise has shown that these can be tackled with minimally invasive endoscopic interventions. Now, endoscopic treatment is still searching for perfection. We still do not have a gold standard to say. A lot of interventions are being done, a lot of new technologies that are coming in to make sure that these debridement procedures can be completed. Now, what is the impact of proportion of necrosis actually? Basically, more than 50% of necrosis, it is associated with increased interventions, increased infections, morbidity, mortality, cost, and surgery. And pancreatic necrosis volume is a new imaging biomarker for acute pancreatitis. So whenever we have necrosis which is more than 50%, it is likely that the intervention that has to be done has to be planned and executed depending on the expertise, depending on the condition of the patient and the extent of necrosis that is seen in this patient. Now, there are a lot of procedures that have come. Laparoscopy is another modality that has come. Now, the biggest advantage of this laparoscopy, again in centers of excellence, is the entire necrosis can be accessed either through transgastric, retrogastric, retrocolic, or retroperitoneoscopic debridements can be done. All potential areas and collections can be accessed. Complete removal of the secrostum is possible, and sometimes it is also possible that you can use a hand port to clear all this. So the biggest advantage of this is if you're going primarily for done in a single stage in majority of the patient with complete evacuation of the systems. And there's a lot of data to show that these procedures are associated with fair good amount of success with a minimal morbidity and mortality. And of course, the complications in this are less if tackled at an early date. And there is a lot of data to show that actually coming in from across our own country, which shows that gastrocolic, transmuscocolic, transgastric intracavitary interventions can be done, and the complications are very, very low in these patients. Now we also have these procedures of single stage retroperitoneoscopy, which can be done through these procedures. We have this trocars, like the optive trocars, like if you're marking out this wall of pancreatic necrosis, instead of putting in a percutaneous catheter, drainage catheter initially, like what is done in Panther trial, now we can go in directly with this trocar, which is almost about 10 to 12 millimeters in diameter. Under vision, we can go this, drain the infected fluid from this, and subsequently we can get into this cavity using laparoscopic instrumentation, which is quite rigid. And this helps, or even putting in a single port like this, and then trying to port or use a TEM scope to do this necrosectomy like this. So this is possible that we able to complete the majority of these procedures in a single stage. And the biggest advantage is that you're directly visualizing these vessels, and majority of these retroperitoneal vessels that are traversing this peritoneum, retroperitoneal space can be avoided, so that massive bleeds can be avoided in these procedures. And again, a lot of data to show that these procedures primarily done can be done with good outcomes, with less morbidity and mortality in this patient. So much so that we talk about so many minimally invasive procedures that are done in current day clinical practice. There is a lot of debate to ask whether open surgery has got any role in current day clinical practice. But again, if you see a lot of data that is coming up, these minimally invasive procedures are done in tertiary care centers and centers of excellence. It is not that this can be practiced, and majority of the people may not be able to reach these tertiary care centers. And there is a lot of data to show that open necrosectomy is done. It can be done with absolutely very minimal morbidity and mortality in these patients, like this huge data which shown that it can be done with minimal morbidity and mortality. Of all the open procedures, the closed continuous lavage is the one which is most practiced. Like in the sense, you do an open necrosectomy, use your fingers to get out the entire necrosum, or use the sponge holding forceps to make sure that you can take out the entire debris, and subsequently irrigate the entire cavity and put drains which can be used to irrigate in the post-operative period till the fluid comes out normally, and subsequently the drains are removed. And if you see the data that is coming out to show that these are associated with very, very minimal morbidity as compared to what is suggested that these procedures are associated with high morbidity and mortality. And even the post-operative fistula rates are very within acceptable limits. Now, there is a lot of data that is coming up from our own centers. Actually, this is a huge data that is coming up from Gangaram Hospital, which showed that in emergency, majority of these patients seem to be going for open necrosectomy. You can see that majority of these patients seem to be going even in open necrosectomy, even in tertiary care centers. And especially in patients who are not able to reach on to the tertiary care center, and in remote centers, there is a lot of data again to show that these patients undergo this open necrosectomy with very good outcomes. So if you can see this primary, if it is done directly, these are associated with very good outcomes in these patients. So open necrosectomy is initially confirmed as a last resort, but it can be used as an initial thing whenever we don't have access to minimally invasive procedures. And it is also done to salvage procedures which have some complications with interventional radiology or endoscopic interventions. Like in this patient who had multiple stents put in for walled-up pancreatic necrosis, which were accidentally migrated into the peritoneal cavity, large pneumoperitoneum here. These patients had to undergo surgery. And you can see this is one such patient who had a peripancreatic fluid collection, which is anterior to the stomach, and these stents were put in. And subsequently, this patient had to be operated and salvaged. And this is a lumen opposing stent that is migrated into the retroperitoneal space that has to be opened up, and the patient had to be salvaged. And you can see this is how the stent is removed. And this is the bleed following putting in a lumen opposing stent, because the margins of the stent are sometimes very sharp and they can erode into the retroperitoneal space. This is one such patient with a large clot in the retroperitoneal space, and you can see that the splenic vein is completely torn in this, leading to massive bleed. And this obviously, no form of interventional radiology or minimally invasive procedure can be helpful in this. These patients require an open surgery to secure these vessels and salvage these patients. Likewise, sometimes it so happens that lumen opposing stents are put in and they're mal positioned into the peritoneal cavity, like this lumen opposing stent which came into the peritoneal cavity through the small bowel mesentery. And you can see this is the small bowel here. The lumen opposing stent has gone through the mesentery of the small bowel. And then you remove this stent from the mesentery of the small bowel. And subsequently, that is the transverse mesocolon here. You can see that that's a transverse mesocolon. That's a colon there. The stent has come through the transverse mesocolon, through the mesentery of the ball. Here again, you open the lesser sac here. And subsequent, once you open the lesser sac here, the transverse mesocolon here. Now this is pulled out from the transverse mesocolon. And subsequently, at the end of the thing, this is the thing that can be removed from the stomach, and you complete the necrosectomy complete subsequently. And likewise, some of these patients have colonic communication, which obviously requires some sort of segmental colectomy in the patient. And if you see, this is a huge data. This I'm very impressed with this data which came sometime before, which has got most of the big people involved in this, endoscopists, interventional radiologists, surgeons involved in this. And this is a practice pattern that is done across 51 hospitals across 8 countries, which still shows that a significant number of these patients seem to be going in for open necrosectomy. But with the increasing expertise, more and more of these people could be going in for minimally invasive intervention. But as of today, it still has a role, and there is a lot of data to show that. This is the data which shows that, and we also have data to show that transgastric procedures, especially walled-up necrosis, which is in good opposition to the stomach, open transgastric necrosectomies are equally effective, and this can be done with minimal complication. And we have this randomized control trial which has come from our own country, which showed whenever the debris is less than 30%, endoscopic and laparoscopic procedures have similar efficacy for internal drainage. So post-IR or endoscopic intervention, majority of these patients have to go for open surgery because it is very difficult to identify walled-up necrosis on laparoscopy. But if the patient is coming for direct surgery, this can be patient either for laparoscopy or retroperitoneoscopy. We in our own department make sure that all these patients, initially majority of these patients used to go for endoscopy. and some of these patients for interventional radiology, but subsequently we realized that a significant patient number of these patients are coming for re-interventions. Now we have a PanCAS board which decide which type of intervention this has to be done. So with the advent of Panther trial, initially most of these patients used to go for IR interventions, and subsequently when endoscopy came in, EOS interventions. But over the period of time, we have shown that significant number of these patients are primarily coming back for surgery. This is the data which show that there are significant number of these patients coming for a primary surgery, wherein the mortality is very, very low as compared to the mortality associated with surgery whenever it is done post-percutaneous or post-endoscopic ultrasound. So this is the algorithm that I feel is the most appropriate. If it is 30% endoscopic expertise is available, you do endoscopic drainage. If it is not available, you do surgery. More than 30% debris, it is open or laparoscopy. If it is beyond the stomach and duodenum, less than 30% debris, you do interventional radiology procedure or open lap or ward procedure. More than 30% debris, again, if the patient is unstable, you do an IR step-up approach followed or open surgery. Stable patient, IR step-up approach or open surgery. Stable patient, you do enteric communication of bleed. These are the patients who require surgery. So if you see in current clinical practice, actually surgery still has a significant role in the management of these patients. And this is a beautiful slide which shown by one of the endoscopists, which shows that patients who have got walled-off necrosis, which are absolutely localized to one area, that is stomach or duodenum, these are best done endoscopically. As the walled-off necrosis goes away from the stomach or duodenum, these are best dealt with surgery. This is a beautiful paper which comes from Sham Varadarajan group, who is a strong proponent of endoscopic ultrasound. So it is one size does not fit in. So it is likely that we should have multiple modalities that have to be practiced based on the expertise that we have, amount of debris, patient state condition, financial status of the patient. All these have to be considered before intervening in this patient with the walled-off pancreatic. Thank you so much once again for the patient here.
Thank you, Rao sir. It was really nice presentations. Before we take the questions from the chat box, I just want to ask a very simple and basic thing, sir. If we have to choose from the endoscopic and the laparoscopic, why should I go through the stomach rather than making a hole in the skin? It means the laparoscopy will give a broader view rather than the endoscopic view for the necrotizing pancreatitis.
This is a very good question that you're asking. I'm not saying that it should be done in laparoscopy. I'm saying whenever the debris is more than 30% and whenever you don't have expertise to do it endoscopically, it can be done laparoscopic cystogastroscopy. Something similar to what you're doing, putting in a lumen opposing stent. But if you have expertise to do it, less than 30% is not a problem for everybody. For majority of the endocrinologists, it's not a problem. But if the debris is more, and if you don't have expertise to do endoscopic necrostectomy, and if it is going beyond the stomach, please think of laparoscopy. That's what I'm trying to say. I'm not saying that it has to be done laparoscopically in all patients, but again, I'm trying to tell you that actually we are biased with tertiary care centers. Actually, we just see what is happening in our centers. We don't see what is happening in the district, 2-tier, 3-tier cities. So there actually significant number of my own surgical colleagues still do significant amount of open necrostectomy in peripheral centers.
Dr. Srinivas?
Yes.
When you started your presentation, you said that we should not consider anything as a mild pancreatitis up to 48 hours. So if the patient comes in OPD, when we should advise the admission for them? Because if we want to categorize them in the mild to severe mode, so we need to monitor them for 48 hours. But every pancreatitis patient we cannot admit. So when should we advise for the admission?
Yeah, exactly. Good one. See, the thing is, the patient just walks into your OP with a pain epigastric region. You need to do some diagnosis to confirm whether it is an acute pancreatitis or not in the first place. So once you make a diagnosis of acute pancreatitis, if the patient is not having severe pain and is not in any of the early SIRS, as I told, tachycardia or hypotension, in such cases, I think you can maybe send him home if he can come.
Srinivas, your voice was interrupted. We couldn't hear you.
Sorry. See,
Yeah.
the thing is, if you are in an OP and if can you hear me now?
Yes, we can hear you
If you
now.
are in your outpatient clinic and you see a patient with acute abdomen, so you will need to do some tests to first diagnose the patient is having acute pancreatitis.
Yeah.
Right? Yeah. So by that time, you will know whether the patient is having any symptoms of systemic inflammatory response syndrome. Like if he's having unusual tachycardia or a hypotension or any tachypnea. If the patient has any of these things, I think it is better to admit the patient for observation for at least 2 days, which we do in a routine practice. We tell the patient that we'll observe you for 2 days. If you're improving, you go home. If you're not improving, you have to stay back and continue the further treatment.
Fine. So there's a question in chat box. When to order the first CT scan and how frequently we should repeat it? Anyone can take. Dr. Srinivas, Dr. Rao, sir.
Yeah. So first, usually if the diagnosis is pretty obvious, for example, the patient is having an history of alcoholic intake, enzymes, MLAs, lipase are very high, and if you got an ultrasound on which is showing a diffusely bulky pancreatitis, so in such cases, CT scan is not required to make the diagnosis. Number one, CT scan, if to be done, you have to delay for at least 24, rather as up to 48 hours for the necrosis to set in. Because early, if you do very early, the patient walks into you maybe 8-10 hours of pain or less than 24 hours of pain. And if you do a CT scan, you may just pick up a bulky edematous pancreatitis. We'll not know whether it is an interstitial pancreatitis or it is going to become a necrotic pancreatitis, acute, moderately or severe necrotic pancreatitis. So if given a chance for diagnosis, avoid CT scan to make a diagnosis of pancreatitis. If the patient is having typical pain, MLA is elevated, and ultrasound showing itself a bulky pancreatitis. But if you're not sure of the diagnosis, then yeah, you can do it anytime within 24 to 48 hours. But once the patient got admitted for acute, moderate, or severe acute pancreatitis, and if the patient is not improving the way you are expecting him to improve, like for example, I told in my slide, if the CRP is persistently high, you can definitely repeat the CT between 7 to 10 days of admission to see whether the patient is developing severe necrosis or a lot of fluid corrections are happening.
So I request our panelists if they want to, Dr. Dhawan and Dr. Pratapan.
Good evening, Dr. Pratapan here. Can you hear me?
Yes, we can hear you.
Yeah, okay. I have to ask questions to all the speakers, starting from the etiology workup. I think the speaker is there. Previously, when we were treating pancreatitis, we were having a tendency to do laparoscopic cholecystectomy when you have suspicion of biliary pancreatitis, especially for edematous type of pancreatitis. Now, I think that trend is gone. So, what is the role of etiology workup in acute pancreatitis? That is my first question to the Mohanty sir. Etiologic workup. How far you go for etiology workup in acute pancreatitis?
Thank you for the question. Actually, we know that the most common three etiologies that precipitate acute pancreatitis is gallstone, alcohol, and hypertriglyceridemia, besides use of some drugs. So this etiology workup is very important when a patient comes with first episode of pancreatitis, so that we can plan out whether he requires only conservative management or he may be requiring an intervention.
Sir, why I ask this question is, in my practice, some of the patients in whom branded as biliary pancreatitis who underwent laparoscopic cholecystectomy, in their late part, they developed frank chronic calcific pancreatitis. So are we missing those cases? That is my concern. Okay.
Pardon?
Can you hear me?
Huh.
Mahandis, sir?
Please repeat the questions.
So why I asked this question was, some of my patients in whom we conducted the laparoscopic cholecystectomy for suspected biliary pancreatitis, in late life they develop full-blown chronic pancreatitis. I think that will be the experience for most of the senior surgeons sitting here. So that is why I asked that question, the workup for pancreatitis, whether it is first episode of an evolving chronic pancreatitis. So the treatment may matter.
Okay. So what I said in the presentation is that there are two varieties of etiologic mechanism. One is inflammatory mechanism, one is fibrotic mechanism. So they both play the role in development of pancreatitis. That's why we see many patients without suffering from any acute pancreatitis or recurrent pancreatitis may go to chronic pancreatitis because of this fibrotic procedure. So, acute inflammation also precipitate or propagate this fibrotic procedure. So, going for cholecystectomy, that's why you may not get a result, and your patient may have chronic pancreatitis after cholecystectomy.
Okay. So regarding the diagnosis of acute pancreatitis, I think you should have the three criteria: the classical pain, elevated serum markers, and the radiology. I think most of the time the pain may be some part similar for other conditions also. I think the diagnosis of acute pancreatitis by the primary care physician may be an important issue, because most of the time when this patient reaches the tertiary care center, that patient might have lost the golden period of resuscitation. So I think at least in our center, I work in a government center where most of the patient may be partially treated for 1 or 2 days in a far-off hospital, and then they will diagnose it as severe pancreatitis and refer to us. So there is no question of the what they call the intermediate severity of pancreatitis, because whatever pancreatitis we see coming as severe pancreatitis will be severe only. I think the primary care physician has to be trained properly for dealing these patients, because we will get patients in a very difficult state. What is your opinion regarding that? Second speaker, severity.
Yes, so
Definitely.
this is the problem with most of the referral hospitals. So as I was telling, if the patient comes with just pain, and as Dr. Vikas was asking, what will you do? Will you admit or will you send him away? So this is what happens in most of the peripheral setup, where the patient comes with some kind of pain, and the physician who is there, who may not even suspect him of pancreatitis, they just treat him as gastritis and send them away. And they come back after 3 to 5 days to a referral hospital in multi-organ failure. So you cannot, first you have to establish a diagnosis of acute pancreatitis, either by amylase, lipase, or an ultrasound, or of course clinical features. So once you know that the patient is in acute pancreatitis, you need to kind of keep him with you either locally or nearest hospital or a district hospital. Give him some fluids and see how the patient is responding, what is happening to his urine output, what is the respiratory rate, and all those things. So this 24, not every patient of severe acute pancreatitis have organ failure on day 1. So this is the most important thing. That's why you need to observe the patient for at least 24 to 48 hours. If the patient is having severe pain, just give him IV fluids and wait for 2 to 3 days to see what is happening. If the patient develops signs of organ failure, you immediately refer him to a bigger center or a regional hospital where you have specialists. Or else, if the patient is improving, that is the definition of mild acute pancreatitis. Patient starts improving from 48 hours onwards. So if the patient is improving 48 hours onwards, you can send him home. If he is not improving, at least you have given him the adequate hydration, which will prevent further organ failure, and you have a timely referral. Because once the patient leaves your clinic, he don't know what he'll do. He may start drinking again, he may start abusing or whatever things he was doing again. So this is very, very important.
Regarding the management and surgical management of acute pancreatitis. I think there is a change in threshold for intervention nowadays because of the increased use of minimally invasive procedures and endoscopic procedures. And previously also we will see severe pancreatitis managed conservatively even without any intervention. I think that set of patient has gone. If you have a patient with collection suspected of Waldorf necrosis or acute onset severe pancreatitis, now there is an increased tendency to intervene. What is the opinion of G.V. Rao sir and the senior sir?
It's a very good question, actually. I mean, I think it is best, actually, as long as the patient is asymptomatic, I think these patients can be managed conservatively because majority of the pseudocysts or wall-off necrosis with minimal debris seem to resolve spontaneously. I think there is a lot of data to show that, actually. Unless and until the patient is symptomatic, I don't think we should intervene in this patient in any form, be it radiological, endoscopic, or surgical.
Even if a big collection or even retroperitoneal air, the patient may be clinically, the radiology may not be correlating well with the patient's general conditions.
Yes. But even big collections, if they're asymptomatic, we just have to, I mean, it is not that initial rule of six does not hold any more in current clinical practice. So as long as the patient is asymptomatic, or if you're having some early satiety symptoms because of compression of the stomach, any of those symptoms, I mean, it requires intervention. But otherwise, I think we can wait as long as possible before we intervene in this patient. I don't think every wall of pancreatic necrosis should be intervened, actually.
Right. The last part which I wanted to ask is about the intervention of patients who develop fistula after your endoscopic or laparoscopic procedure, because we see a lot of patients who underwent the interventional radiology procedure or even surgical drainage developing fistula. How long will you wait for these fistula to close, or we need to intervene these patients in a very time frame manner, because most of them will lose their nutrition and we don't know how to intervene, when to intervene these patients?
Now, it's a very good question. Actually, I keep arguing with my endoscopists who keep saying that all patients with surgery, they develop fistula. Please. Now, patients, actually, if you compare apples to apples, actually, you're doing EUS drainage to wall-off necrosis in opposition to the stomach or duodenum. Same thing, you do a cystogastroscopy, so obviously there is no fistula. Patients who develop fistula are the patients who have this extensive necrosis beyond the stomach and duodenum, which are not amenable to drainage into the stomach or duodenum. That is, yeah. So these are the patients who develop fistula. It is something like you talking about a disconnect pancreatic syndrome in following endoscopic drainage. So these patients actually, because the same thing happened. These patients, don't develop a thing here, but they develop a fistula here. Majority of the time, again, they develop this disconnect syndrome, like what happens in the endoscopy side also. Majority of the patients resolve. Now, there are some set of patients, yes, who do not respond to these things. And these are the patients who can undergo surgery. Now, surgery is done either in the form of a fistulojejunectomy. There are many techniques that are available which can be done. But again, these are all open surgical procedures associated with certain amount of morbidity. But again, you cannot say that all surgical procedures are associated with fistula. Patients who undergo cystogastroscopy don't have any fistulas. It is only these patients who are drained, either, I mean, through the patients who undergo this interventional radiology procedures or extensive necrosectomy, and then you put in these things. These are the patients who can undergo this thing. But we usually wait again as long as possible. The amount of drain is not very high in this patient. Majority of the patient is subsides over the period of time.
Thank you. Okay.
There is a question in chat box that should the patient with decreasing trend of LFTs with normal CVD and gallstone on ultrasound should undergo the ERCP? Dr. Nistla.
No, sir. This itself is very clearly showing that the patient is having a decreasing trend of LFT. CBD is normal, only gallstones. See, the natural history of impacted gallstones is majority fall off. Majority of the impacted CBD stones, more than 80 to 90% or more than 90%, they have a spontaneous passage of gallstones from the CBD. So if the patient is otherwise not in cholangitis, only mild LFT raise, you wait for next 24-48 hours. If the LFT is showing a decreasing trend, we don't do ERCP. We should not do ERCP in this patient.
Dr. Jayanta is there? Dr. Jayanta, sir?
Yeah. I am here.
Yeah, you can ask your question, sir. You have kept it in chat box.
No, I was asking in laparoscopic necrosectomy, is there any use of resectoscope used in for TURP type of thing? We can cut that necrotic tissues into pieces and remove that.
Yeah, it's a very good question. Actually, the nephroscope. I mean, these are the what the urologists use because they have a channel to this thing. These can be used, yes, to do the debridement. There are some surgeons who practice this here. Actually, it is something like having a TEM scope. It has got an operating channel, so it becomes easier to pass this instrument and do a debridement. If you have a thing, yes, you can use it for the procedure.
Thank you.
Dr. Jayanta, if I can add to your thing, uh, uh, of course, in surgery, they have a lot of instruments, but even in endoscopic necrosectomy, when the necrotic debris are more, initially we put up lamps. We wait for 24 to 48 hours to see how much of the liquid debris have drained out. Liquids have drained out. Then we go in after 24 to 48 hours to see whether the stent is patent or not, or the mouth of the stent is blocked by the necrotic debris. We'll pull out initially with simple instruments like a basket or a roth net or a snare. But nowadays we have two different instruments which have come up, which are literally, we can go into this. I can't show you the picture now, but what you are telling is specific instruments have been developed for the endoscopic necrosectomy, wherein we can catch hold of the necrosum with a cup-like thing, almost 1.5 to 2 centimeter in diameter. We can catch hold of those debris and pull them out.
Yeah, absolutely right. Actually, there are two things. One is that large cup that are available. The other thing is that rotator sort of a thing that is available to
rotator thing. Yes.
Yeah, these are the two techniques that are available in currently clinical. Yeah, these are been centers of expertise. Actually, they have getting more and more of this equipment into this thing, and they're able to do this routinely.
So the another very similar question is there. That's can we go for ERCP and cholecystectomy in same setting in moderate pancreatitis with decreasing biochemical parameters? But I think when there is a decreasing biochemical parameters, we are not going for the ERCP, right, Dr. Nistala?
Yes, I mean, if the LFTs are improving within 24-48 hours, there's no role of ERCP.
Yes.
But yes, if the patient is having only mild acute pancreatitis, we can do a lab chole if the diagnosis is certain that it is biliary pancreatitis. In the same admission, as soon as the patient clinically improves, we can go for a lab chole without going for an ERCP. GV Rao, sir, I think that is the standard you follow at your place, and
this is the standard that we follow actually. In acute pancreatitis, yes. Actually, but I slightly deviate when we do for elective laparoscopic cholecystectomy. I strongly do not do the thing in the same sitting. Neither I do it the next day. I wait at least for about 24 to 48 hours before we take the patient for lab cooling. This is basically
once
because
the patient settles.
Yeah, some patient might develop acute pancreatitis. You understand, actually, post-ERCP pancreatitis, which is very difficult to manage in these patients. So, in acute pancreatitis is a different setting, but in elective setting, actually, we usually wait for some time before we take this patient.
Right.
But it is in the same hospitalization time.
Yes.
So then the next question is how much the incidence of fistula post necrosectomy, and is it differ according to different cause of pancreatitis?
Different cause of pancreatitis, no. Different types of interventions, yes. And based on the degree of pancreatitis.
Severity. Yeah. Among the all biochemical investigation, which is more better for diagnosis?
The most specific one is lipase, because only pancreas is the only organ which kind of produces lipase. Amylase has multiple sources. Even salivary gland produces amylase. So if you have those kind of doubts, if you have lipase available at your center, lipase is the first to be done. But it rises quickly, falls down quickly. That is the problem with lipase. Amylase rises a little late, maybe 12 24 hours after the acute onset, stays for a longer period. Amylase rises 6 to 10 hours in the onset of the disease and then falls down very quickly. So if you want to kind of foolproof your diagnosis without any discrepancies or without any ambiguities, lipase is the test to be done. But you may miss it if you're not doing it at the correct time. Because if the patient has some amount of renal failure, if the patient has some amount of intestinal injury, see, pain abdomen can be because of pancreatitis or can be because of some intestinal obstruction or intestinal injury. Small bowel also has small bowel injury also produces amylase, and hyperamylasemia is also seen in patients with renal failure. If the patient is having acute renal failure and pain abdomen, you can have some amount of amylase elevation seen in those kind of patients. So, but that is not because of pancreatitis.
So, Dr. Rao sir, for the laparoscopic necrosectomy, is the retrocolic approach and the putting big drains will pose more risk for the fistula?
No, see, basically, whenever we try to do an access, it all depends on the most dependent area and where the wall of necrosis is pointing to. If it is pointing to the mesocolic area, absolutely, there is a small possibility that, it can cause some amount of complication because it's going through the transverse mesocolon, but the morbidity mortality is not very different between these different axes actually.
Dr. Dhawan is there? Dr. Dhawan? I think he has left. So, and Dr. Manas Sahu, sir, if you want to add something. Yeah.
Dr. Vikas, there is this one question, I think, regarding the timing of cholecystectomy. I saw it in the chat box.
I missed probably. You can take this, sir. Yeah.
It just
Is the
propped up on my screen, so I'll just take this.
Sure.
Same question. What is the time of cholecystectomy in pancreatitis? I think it was already answered. Mild pancreatitis, same admission, 48 to 72 hours later, you can operate. Moderate to severe, you have to wait for the patient to completely settle, maybe 3 to 4 weeks after that, SS, and then do it.
Fine. So, if there is no question, we can conclude the session. Dr. Niharika? Niharika?
Yes, sir, I'm here.
Yeah. Yes.
I speak before you filled with immense gratitude as we conclude the TUGSS India academic meet on basics of pancreatitis management. In this digital realm, our collective dedication to knowledge sharing has transcended physical boundaries, making this a truly enlightening and enriching experience for all of us. Firstly, on behalf of the TUGSS family, I would like to express my sincere gratitude to our distinguished speakers for today, Dr. Rashmi Ranjan Mohanty, Dr. Nishtala Srinivas, and Dr. G.V. Rao, who delved into the intricacies of pancreatitis management and shared their valuable knowledge and expertise. Your presence has made today's session an enriching and inspiring experience for all of us. I also extend my heartfelt appreciation to our esteemed panelists, Dr. V.K. Pratapan, Dr. Manohar Dhawan, and Dr. Sharad Malhotra. Your expertise and has broadened our understanding and will undoubtedly impact the medical landscape. I would also like to thank Dr. Manas Ranjan Sahu for coordinating this session and bringing together such an esteemed panel of speakers and experts in the field and ensuring a smooth and productive session. I extend my sincere thanks to each and every one of you for taking out time from your busy schedules and actively engaging in this virtual discourse. Your questions, contributions, and shared experiences have made this session intellectually stimulating and worthwhile. A special word of appreciation goes out to Dr. Vikas Jain, our TUGSS Asia and India Chief. who works tirelessly behind the scenes to make up the programs possible. Your dedication, meticulous planning, and attention to detail are commendable, sir. Our next program, the TUGSS India Academics Meet, is scheduled to be held on the 8th of March on hiatus hernia. You can register for the meeting through the same QR code as today, which is also displayed on your screen right now. Lastly, I would like to request everyone to spread the word about our Society of the Upper Gastrointestinal Surgeons amongst your colleagues, friends, and peers to join and benefit from the webinars organized. As we log off, let's carry forward the insights gained and continue to push the boundaries of medical excellence. This is Dr. Niharika Agarwal signing off. Have a great evening. Thank you.
Thank you, everyone. Thank you, sir. We can log off now. Thank you.